Welcome to the deep dive. Today, we're plunging into, well, a really fascinating and crucial area, disorders of coagulation and hemorrhage.
Yeah, it's fundamental stuff.
You sent in a really comprehensive chapter on this, and our mission is basically to pull out the key insights, connect the dots in this complex system of how our bodies stop bleeding and what happens when that goes wrong.
Right.
Think of this as your shortcut to getting a handle on the essentials.
That's right. We'll be navigating from the basic definitions and how doctors diagnose these things,
Okay.
all the way through the different kinds of bleeding conditions, inherited, acquired, and then, how we actually manage bleeding when it happens.
The goal is clarity, right? A
Yeah.
structured understanding of what really matters here.
Exactly, without getting totally bogged down in every single detail.
Okay, let's unpack this then. First things first, what exactly are we talking about with coagulopathy and hemorrhage? Sounds simple, but I feel like there's more to it than just, bleeding too much.
Absolutely. Hemorrhage is pretty straightforward, excessive bleeding. But coagulopathy,
Yeah.
that's the broader term. It means abnormal blood clotting.
Abnormal. Okay.
Now, what's interesting, and maybe a bit counterintuitive, is that while we usually link it to bleeding problems,
Yeah.
technically, it can also mean a tendency to form unwanted clots,
Yeah.
thrombosis.
Ah, right. So it can go both ways.
It can.
Yeah.
But, in day-to-day clinical practice, when someone says coagulopathy, they're almost always talking about the bleeding risk side, problems with clotting enough.
Got it. So it really comes down to that super fine-tuned balance we always hear about coagulation making the clot and fibrinolysis, breaking it down, like our body's internal seesaw constantly adjusting.
Precisely. That equilibrium is absolutely vital. Whenever there's a vascular injury, we need to clot effectively to stop the leak, right?
Right.
But we also need fibrinolysis to kick in and make sure those clots don't overstay their welcome and block blood flow. It's a constant push and pull.
And why is understanding this balance so critical, especially for patients with vascular disease or those heading into vascular surgery?
Well, there are a few key reasons.
Mhm.
First, these patients often have existing conditions that mess with this balance already.
Okay.
Second, they might be on meds like antiplatelets, anticoagulants that deliberately shift the balance to prevent clots.
But that raises the bleeding risk.
Exactly. It's a side effect we accept for the benefit, but it's a risk. And third, the surgery itself, sometimes needing anticoagulants during the procedure.
Yeah.
That just adds another layer of complexity.
Makes total sense. So figuring out who's at higher risk before surgery seems like a really critical first step. How do clinicians actually approach screening for these bleeding disorders? It can't just be a single blood test for everyone, can it?
No, definitely not. It's much more nuanced. It's really a risk-stratified approach.
Risks stratified.
And it always starts with a really thorough patient history and a physical exam. The main goal there is just to identify people who might have an underlying bleeding issue hiding somewhere.
So what kinds of questions are they asking? What are the red flags in that history?
And key questions are all about past bleeding. Did you bleed a lot after other surgeries?
Yeah.
Dental work, trauma, childbirth.
Real-world challenges to the system.
Exactly. They'll ask about frequent nosebleeds, easy bruising, blood in the urine or stool, heavy periods for women. Because sometimes, a bleeding disorder doesn't really show itself until the system is seriously challenged.
And I saw a mention of the ISTB, that bleeding assessment tool. What's that about?
Yeah. That's a standardized questionnaire from the International Society of Thrombosis and Hemostasis. Just a systematic way to score someone's bleeding history. Helps assess risk and decide if more tests are needed.
Useful tool, then.
Very. And family history is huge, too. If close relatives had serious bleeding problems, that's a major flag.
Right.
And, of course, you need a complete list of everything the patient takes. Prescription drugs, over-the-counter stuff, even herbal remedies. Lots of things can mess with platelets or clotting factors.
Yeah, something seemingly harmless could throw a wrench in the works. What about the physical exam? What are clinicians looking for there?
The exam can give clues, too. Tiny red spots called petechiae, lots of bruising.
Okay.
Signs of liver disease like an enlarged liver or spleen, or those little spider veins, spider naive. Even swollen joints from past bleeds. It all adds to the picture.
So history and physical first, then lab testing. When does that come in, and how do they choose which tests? Because, like you said, there are quite a few.
Exactly. You need a systematic approach. That's where risk stratification really helps. Rappaport scheme, mentioned in the chapter, is a good example. It uses 4 levels based on bleeding history and the type of surgery.
Okay, let's walk through those levels quickly. Level 1.
Level 1, minor surgery, no bleeding history. Basically, no routine testing needed here. The chance of finding something significant is just too low to justify the cost and hassle.
Makes sense. Level 2.
Level 2, major operation, still no bleeding history. Here, you typically get the basics, a PT, an APTT, and a platelet count, just to screen for any major issues that could cause life-threatening bleeding.
Okay, that covers the no suspicion cases. What if the history is a bit concerning?
That's level 3. So, a suspicious history, or the procedure itself messes with hemostasis, like high-dose heparin in cardiac surgery.
Right.
Here you do the PT, APTT platelet count, but you might add more, maybe a bleeding time, or more likely now, a PFA 100 to check platelet function, possibly factor 13 levels, or screening for fibrinolysis issues if there's a history of delayed bleeding.
Got it. And level 4 must be when the suspicion is really high.
Correct. Level 4 is for patients where the history or exam strongly suggests a bleeding disorder, regardless of the surgery planned.
So pull out all the stops?
Pretty much. All the level 3 tests, plus specific factor assays, usually 8 to 9x for hemophilia, Thrombin Time, TT, to look at fibrinogen, and definitely a PFA 100. It's generally preferred over bleeding time now for VWD or platelet issues. Sometimes even a bleeding time after aspirin. And crucially, for level 4, even if those initial tests are normal, but you're still suspicious, you really need a hematology consult.
That clarifies the tiered approach. Now, it's not just ordering the right tests, it's getting them right, isn't it? The chapter stresses proper blood drawing. Why is it so critical?
Oh, absolutely critical. The ratio of blood to the citrate anticoagulant in the tube has to be precise, usually 9 to 1.
9 parts blood, 1 part citrate.
Exactly. And the tube has to be filled properly. Underfilling messes up that ratio, gives falsely prolonged results. Gentle mixing is key too, and getting the sample tested within specific time limits, usually a couple of hours at room temp. Get that wrong, and the results are unreliable.
Okay, technique is non-negotiable. Let's dive into some specific tests now. PT and APTT, we've mentioned them a lot. What do they actually measure?
Right. The prothrombin time, PT, mainly checks the extrinsic pathway that involves factor Ceph and also the common pathway factors 2, VX, and fibrinogen.
So it's looking at a specific part of the cascade.
Yes. It's famously prolonged by warfarin, the vitamin K antagonist. But interestingly, high doses of some other drugs, like the direct thrombin inhibitor argatrobin, or even really high heparin doses, can prolong it too.
Good to know. And the APTT activated partial thromboplastin time.
The APTT looks primarily at the intrinsic pathway factors, 8th, 9, 8s, 812, plus that same common pathway.
Different branch, same meeting point.
Sort of, yeah. Its main jobs are monitoring standard heparin therapy, detecting lupus anticoagulants, and picking up deficiencies like hemophilia A, factor 8, and B, factor 9X.
So PT checks one side, APTT checks the other, both leading to the final clot.
In simple terms, yes. But remember, a prolonged result needs context. It doesn't automatically mean one specific thing.
Right. What about the thrombin time, TT? Sounds like it's focused on the very end of the process.
That's exactly right. TT directly measures how fast fibrinogen converts to fibrin, that final step.
So if that's slow,
It could mean direct thrombin inhibitors are present, or heparin, or clot-busting drugs, or conditions like DIC, or maybe the fibrinogen itself isn't working right. That's dysfibrinogenemia.
and the ACT, activated blood clotting time, is that like a quick bedside version?
Pretty much. ACT is a rapid whole blood test giving a global look at clotting, used a lot in the OR or cath lab, especially for monitoring heparin during procedures like cardiac surgery, point-of-care testing.
Okay. We also saw bleeding time and PFA 100 listed for primary hemostasis. What's the difference, and why is bleeding time less popular now?
The bleeding time was the old way. Make a small cut, time how long it bleeds. Simple idea, testing platelet plug formation.
Right.
But it's really hard to standardize. Results vary a lot. And critically, studies showed it wasn't actually that great at predicting surgical bleeding risk. So it's fallen out of favor mostly.
And the PFA 100 stepped in. How does that work?
The platelet function analyzer 100, PFA 100, is more modern, automated. It sucks blood through a tiny hole coated with stuff that activates platelets, collagen, plus epinephrine or ADP. It measures the time it takes for platelets to plug that hole, the closure time.
Yeah.
If it takes too long, it might suggest aspirin effect, a platelet defect, or von Willebrand disease, more reproducible than the old bleeding time.
And you mentioned some antidepressants can affect it?
Yeah, that's something to keep in mind.
Yeah.
Certain SSRIs, for instance, can prolong the closure time.
Good point. Okay, PFA 100 gives a better look at platelets. What about TEG and Rotem? They sound more advanced.
They are thrombolistography, TEG, and rotational thromboelistometry, Rotem. These are sophisticated point-of-care tests.
What do they show you?
They give a real-time dynamic picture of the entire clotting process. How fast the clot forms, how strong it gets, how quickly it breaks down, even if there's excessive fibrinolysis happening.
Wow, like watching a movie of the clot.
Kind of, and because you get results relatively fast, they're really valuable during complex surgery like cardiac or in major trauma or postpartum hemorrhage. Helps guide exactly which blood products are needed. Goal-directed therapy.
That sounds incredibly useful. What about fibrin degradation products, FDPs? We hear about D-dimer a lot. Is that related?
Yes, D-dimer is a specific type of FTP. FTPs are basically the leftover fragments when plasmin breaks down fibrin during fibrinolysis.
So high levels mean clot breakdown is happening?
Exactly. You see high levels in DIC, liver disease, eclampsia, trauma, after clot-busting drugs. It tells you fibrinolysis is active, but the overall FTP test itself, beyond D-dimer's specific uses, has somewhat limited pinpoint applications.
Okay. And finally, the euglobulin lysis time, ELT. Sounds specific to clot breakdown again.
It is. ELT measures the overall activity of the fibrinolytic system in plasma, how fast a clot dissolves in a test tube, basically.
What's its main use?
It's mainly used to help tell the difference between primary fibrinolysis, where the body's just breaking down clots too much on its own, and the secondary fibrinolysis you see in DIC.
How does it help distinguish?
A short ELT without low platelets or fragmented red cells suggests primary fibrinolysis. A short ELT with those other DIC features points more towards DIC. It can also give clues about TPA and PAI1 levels, but results can vary a lot between labs.
Okay, that covers the diagnostic toolbox pretty well. Let's shift now to the coagulopathies themselves, the bleeding disorders. The chapter classifies them as inherited versus acquired and also by primary versus secondary hemostasis. Can you unpack that?
Sure. So inherited means genetic, passed down. Acquired means it develops later due to other conditions or factors.
Okay.
And the primary versus secondary distinction relates to where the problem is. Primary hemostasis is about platelets and the initial plug formation. Problems here usually cause skin and mucous membrane bleeding, nosebleeds, bruising, gum bleeding.
Got it. And secondary?
Secondary hemostasis is about the coagulation cascade, making that stable fibrin clot. Defects here tend to cause deeper bleeds into joints, muscles, internal organs, or more severe bleeding after surgery or trauma.
Let's start with the inherited ones. Von Willebrand disease, VWD, you said it's the most common.
By far. It's due to a problem with von Willebrand factor, or VWF. Either not enough of it, or it doesn't work right.
And VWF does.
Two key things. It helps platelets stick to injured vessel walls, crucial for that primary plug. And it acts like a bodyguard for factor VIII in the blood, protecting it.
So it's involved in both primary and secondary hemostasis in a way.
Exactly. Which is why it's so important. It affects maybe 1% of the population, but interestingly, only a small fraction, maybe 5% of those affected, actually have significant bleeding symptoms.
What kind of symptoms do they typically get?
It varies hugely, from nothing noticeable to severe bleeds. But common things are easy bruising, nosebleeds, gum bleeding, heavy periods, bleeding after dental work or surgery. Sometimes taking an NSAID like aspirin is what first uncovers it.
And there are different types of VWD.
Yes, 3 main types plus subtypes. Type 1 is the most common, just a quantitative deficiency, meaning not enough normal VWF. Type 2 involves qualitative defects. The VWF protein is there, but doesn't function properly. There are subtypes here like 2A, 2B, 2M, 2N, each with a specific functional issue.
And type 3.
Type 3 is the most severe, very little or no VWF protein at all.
So the type really dictates severity and treatment.
Absolutely. Initial screening might involve a PFA 100, platelet count, maybe an APT. Then you do specific tests, VWF antigen level, VWF activity like the risk-stratified cofactor test, factor VIII level, and even blood type matters. Type O people tend to have lower VWF levels naturally.
And treatment.
Highly tailored. Avoid NSAI generally. For type 1 and some type 2, a drug called desmopressin, DDAVP, can work for mild bleeds or minor procedures. It boosts VWF release from storage.
What about the more severe types?
For type 3 or severe type 2, you usually need replacement therapy. Concentrates containing VWF and factor VIII are the mainstay, aiming for factor levels between 50 and 100% around surgery or major bleeds.
Moving to other inherited platelet issues, you mentioned giant platelet disorders. What are those about?
These are rare, characterized by low platelet counts, abnormally large platelets, and bleeding. Bernard-Solio syndrome is a key example.
That's the defect there.
It's a problem with a platelet surface receptor complex, GPIEIXV. This complex is what binds VWF, allowing platelets to stick to the vessel wall, so adhesion is impaired.
And clinically?
Patients often present early with nosebleeds, gum bleeding, bruising. Bleeding after surgery can be significant. Lab tests show low counts, big platelets, and a long bleeding time. Management is mostly avoiding trauma and using platelet transfusions for serious bleeds.
What about Glanzmann thrombasthenia? How is that different?
Glanzmann's is another rare one, but the defect is in a different platelet receptor, GPIBI. This one is essential for platelets sticking to each other aggregation.
So they can stick to the wall okay, but not clump together.
Exactly. Adhesion is okay, aggregation is severely impaired.
Lead into
Mucocutaneous bleeding mainly. Lab tests show virtually no platelet aggregation in response to agonists. Treatment, again, often involves platelet transfusions, sometimes recombinant factor Ia if antibodies develop.
Then there are storage pool disorders. Sounds like the platelets are missing some internal cargo.
Precisely. Platelets have granules alpha and dense granules that store and release important stuff for clotting. These disorders involve defects in those granules.
Like what?
Gray platelet syndrome is an alpha granule defect, causes mucosal bleeding, long bleeding time, often mild thrombocytopenia. DDAVP or platelets might help. Dense granule defects can be part of syndromes like Wiskott-Aldrich, that's an X-linked immunodeficiency with small dysfunctional platelets, eczema, and immune issues.
Treatment for something like Wiskott-Aldrich.
For severe cases, bone marrow transplant is the only cure. Platelet transfusions need to be carefully selected, HLA matched, and irradiated.
Okay, we absolutely have to talk about hemophilia. Probably the best known inherited bleeding disorder. What's the core issue?
Hemophilia A and B are the common ones, both X-linked recessive. Hemophilia A is a factor VIII deficiency. Hemophilia B is factor IX deficiency.
Both crucial for the cascade.
Absolutely. They're needed for that amplification step leading to a proper thrombin burst. Without enough thrombin, you can form an initial platelet plug, but you can't stabilize it effectively with fibrin. So secondary hemostasis fails.
And how do they present? Are A and B similar?
Clinically, very similar. The hallmark is bleeding into joints, hemarthrosis, and muscles, often spontaneous in severe cases or after minor trauma.
Lab findings.
The key finding is a prolonged APTT. Then you confirm with specific factor assays showing low factor VIII or IX. Severity, mild, moderate, severe, depends on how much factor they actually have. Less than 1% is severe.
Management has changed a lot, hasn't it?
Hugely. The main goal is replacing the missing factor to prevent or treat bleeds. DDAVP can sometimes boost factor VIII in mild hemophilia A.
But for moderate or severe.
You need factor concentrates, either plasma-derived or, more commonly now, recombinant. Before surgery, you aim for high levels, like over 80%, then maintain them around 30–50% for a couple of weeks post-op.
What about inhibitors? That's a major challenge, right?
Huge challenge. The patient's immune system makes antibodies against the replacement factor. If that happens, you might need bypassing agents like recombinant factor E or activated prothrombin complex concentrates, APCCs. They kind of skip over the need for eighth or IX.
Any other strategies for inhibitors?
Immune tolerance induction, ITI, tries to desensitize the immune system. And more recently, there's emicizumab for hemophilia A.
How does that work?
It's a non-factor therapy, a monoclonal antibody. It essentially mimics factor VIII's job, bridging factor X and Xins. Works even if inhibitors are present.
But potential issues.
It can interfere with some lab tests, and there's been a risk of thrombosis if given with APCCs in inhibitor patients. Needs careful management. And briefly, there are rarer deficiencies of other factors too. AAX, 7V2, 13, usually autosomal recessive, often less severe bleeding.
Okay, that's a great overview of inherited disorders. Let's switch to acquired coagulopathies. First up, acquired platelet disorders. Common causes.
Can be either low platelet count thrombocytopenia or poor platelet function. Low counts can come from liver disease, cardiopulmonary bypass, big spleens trapping platelets, cancers like leukemia, many drugs,
Right.
or specific conditions like TDP or ITP. Poor function, even with normal counts, is classic in uremia kidney failure.
So if someone has a low count from, say, liver disease or a drug and needs surgery,
Often, the management involves platelet transfusions to get the count up to a safer level for the procedure.
but ITP is different. Immune thrombocytopenic purpura.
Yeah, that's an exception. The body's attacking its own platelets. Transfusing more often doesn't help much. They just get destroyed too. So pre-op treatment there is usually IVIG or steroids to calm the immune system down, maybe thrombopoietin mimetics to boost production.
You mentioned uremia causing platelet dysfunction. How does kidney failure mess with platelets?
It's complex, not fully understood. But uremia seems to cause intrinsic problems within the platelets themselves and also affects how they interact with the blood vessel lining. Changes in surface receptors, granule release. stuff like that.
How does that show up clinically?
Easy bruising, mucosal bleeding like nosebleeds.
Yeah.
But interestingly, the standard PT, APTT, and platelet count are usually normal.
So how do you treat bleeding in uremia?
If it's serious bleeding or before major surgery, correcting anemia helps. DAVP can boost VWF release. Sometimes conjugated estrogen is used. But the best long-term fix for uremic issues, including bleeding, is usually dialysis.
Vitamin K deficiency, another acquired issue. We know vitamin K is vital for clotting. How does deficiency cause problems?
Vitamin K is needed to properly activate factors 2, 7, IX, and X, plus proteins C and S. Without enough vitamin K, the poor diet, absorption problems, or taking warfarin in the liver makes dysfunctional versions of these factors.
How do you fix that quickly if someone's bleeding or needs urgent surgery?
Two main ways. You can give FFP or prothrombin complex, concentrates, BCCs. They provide functional factors immediately. That's fast.
Okay.
Or you give vitamin K itself. That lets the patient's liver make its own functional factors, but it takes hours to work. So for emergencies, FFP or PCCs are usually first, maybe with vitamin K for a longer lasting effect.
Let's tackle DIC. Disseminated intravascular coagulation. Sounds really serious. What's actually happening?
It is serious, often life-threatening. DIC means widespread systemic activation of coagulation. Basically, clotting goes haywire throughout the body.
Leading to clots everywhere.
Yes, tiny clots form in the microvasculature, which can block blood flow and damage organs. But paradoxically, it also causes bleeding.
Clotting and bleeding, how does that work?
It's complex. DIC is always secondary to something else: sepsis, major trauma, certain cancers, obstetric emergencies like amniotic fluid embolism. These triggers cause massive uncontrolled thrombin generation. This forms fibrin clots everywhere, using up clotting factors and platelets faster than the body could make them. That's the consumptive coagulopathy, leads to bleeding.
And the clotting itself.
The widespread clotting also activates the fibrinolytic system to try and break down those clots. But this excessive fibrinolysis can also worsen bleeding by breaking down factors and any clots that do form. It's a vicious cycle. Can present acutely with bleeding or more chronically with thrombosis.
How do you diagnose and manage something so chaotic?
Diagnosis uses clinical picture plus labs, usually prolonged PT and APTT, low platelets, low fibrinogen, and high FTPs or D-dimer, showing that consumption and breakdown. Scoring systems like the IST criteria help.
And management.
Most important, treat the underlying trigger, absolutely critical. Then supportive care replace factors and platelets if bleeding, maintain perfusion, correct acidosis. Anticoagulation is controversial, maybe for chronic DIC with thrombosis, but usually avoided at acute bleeding DIC.
Primary fibrinolysis disorders, how are they different from the fibrinolysis in DIC?
In primary fibrinolysis, the main problem is just the fibrinolytic system being overactive. Too much plasminogen activator or not enough inhibitors.
So just excessive clot breakdown.
Essentially, yes. Plasma gets activated pathologically, overwhelms inhibitors, and starts degrading fibrin and clotting factors like V and 8. Leads to bleeding. Sometimes, paradoxically, it can trigger some thrombosis too. But the key is distinguishing it from DIC because the treatment is different.
How do you tell them apart?
It can be tricky. A short euglobulin lysis time, ELT, without the low platelets and fragmented red cells typical of DIC, points towards primary fibrinolysis. Causes include some cancers, liver failure, trauma, rare genetic inhibitor deficiencies.
Treatment for primary fibrinolysis.
Mainstay is antifibrinolytic drugs, aminocaproic acid, tranexamic acid to block that excessive plasmin generation. Plus, you might need to replace the factors that got chewed up, like V and 8.
Okay, let's talk drug-induced issues. Very relevant. Heparin's first unfractionated, UFH, and low molecular weight, LMWH. How do they work?
Heparins work by binding to and supercharging antithrombin, a natural anticoagulant. This complex then rapidly inactivates thrombin, factor Ti and factor Za, and some others.
How are UFH and LMWH different?
UFH is emissive sizes, inactivates both thrombin and Za-K. Usually given IV, monitored with APTT or ACT. Short half-life, importantly, it can be fully reversed with protamine sulfate.
LMWH.
LMWH is like enoxaparin are smaller fragments. They preferentially inhibit factor Za more than thrombin. Given subcutaneously, more predictable response, often no monitoring needed. Longer half-life, but protamine only partially reverses them.
And the big risk with both is HIT.
Yes, heparin-induced thrombocytopenia, an immune reaction causing platelet activation and paradoxically a high risk of clotting. Serious complication.
What about direct thrombin inhibitors, DTIs? How are they different?
DTIs like argatroban or bivalirudin bind directly to thrombin itself, inactivating it. They don't need antithrombin.
Why is that useful?
Crucially, they work even on thrombin stuck inside a clot, and they're the go-to treatment for HIT because they don't trigger that immune response. More predictable effect than heparin 2,
Downsides.
can be expensive. Clearance might depend on kidney or liver function, and some lack specific reversal agents, though idarucizumab reverses dabigatran, an oral DTI, usually monitored with APTT, sometimes ACT for argatroban.
Warfarin, the classic oral anticoagulant. How does that work again?
Warfarin blocks vitamin K activation, so it stops the liver making functional versions of factors 2, 7-IXX, and protein CNS.
It takes a few days to work.
Right, usually 2-3 days for full effect.
Yeah.
And because it hits anticoagulant protein CNS first, they have shorter half-lives. There's a brief prothrombotic risk initially. That's why you often bridge with heparin or LNWH when starting warfarin.
Reversal.
Vitamin K works, but slowly. For rapid reversal and bleeding, you need FFP or PCCs. Warfarin-induced skin necrosis is a rare but nasty complication too.
And the DOACs. Direct oral anticoagulants? Rivaroxaban, apixaban, dabigatran, how do they fit in?
DOACs are newer, work by directly inhibiting either factors A's, the Zabins, or thrombin, dabigatran.
Advantages.
More predictable effect, fixed dosing, usually no routine monitoring, fewer interactions than warfarin,
Yeah.
great for VTE treatment prevention, AFib stroke prevention,
Limitations.
maybe less effective in antiphospholipid syndrome or with mechanical heart valves. Use might be limited in pregnancy, severe liver disease, some GI issues, but their shorter half-lives are useful for surgery planning.
Reversal agents exist now, too.
Yes, idarucizumab for dabigatran and dexedrine alpha for the ACE inhibitors. Big step forward for managing major bleeding. Otherwise, management is stopping the drug, local measures, transfusion if needed.
Finally, antiplatelet agents, aspirin, clopidogrel, not anticoagulants, but still increase bleeding risk.
Absolutely. They target platelets, crucial for primary hemostasis. Aspirin irreversibly blocks COX-1, reducing thromboxane A2 needed for activation.
Clopidogrel and others.
Thienopyridines like clopidogrel, prasugrel block ADP receptors, also inhibiting activation. Since platelets can't make new enzymes, the effect lasts their lifespan 7–10 days. Need new platelets from bone marrow.
Stopping them before surgery is tricky, right? Especially with stents.
Very tricky.
Mhm.
Often guidelines favor continuing them if the thrombosis risk off outweighs the bleeding risk on, especially after recent stents. Delaying elective surgery is key for stent patients. If stopping is needed, usually 5 days before for clopidogrel to ticagrelor.
Any reversal.
Not really specific reversal agents. 4-BGPI-BI inhibitors like abciximab have shorter effects, can sometimes be countered partially by platelet transfusion. Newer agents like ticagrelor have faster offset, offering maybe bridging potential.
Okay, that covers the drugs. The chapter also mentions other factors: hypothermia, acidosis, dilution. How do they worsen bleeding?
Yeah, these are critical, especially in trauma or big surgeries. Hypothermia, low body temp just slows down all the enzymatic reactions in the coagulation cascade. Makes everything sluggish.
And lab tests might look okay.
Right, because labs run tests at 37 degrees C, so the results can be falsely reassuring. Keeping patients warm, normothermia is vital.
Acidosis.
Low blood pH also impairs coagulation enzyme activity and complex formation. Need to treat the underlying cause, sepsis, shock, whatever is causing the acidosis.
And dilution.
Giving large volumes of fluids or even just red cells dilutes the concentration of clotting factors and platelets. That's dilutional coagulopathy. Why massive transfusion protocols emphasize balanced resuscitation with plasma and platelets alongside red cells.
Okay, we've covered causes. Now, actually treating bleeding, what's the overall approach?
First, figure out the cause if possible and tailor therapy to that. Always prioritize maintaining perfusion, getting oxygen to tissues. Then blood and factor replacement are often key.
Let's run through those. Packed red blood cells, PRBCs.
Main job is restoring oxygen carrying capacity. Used for acute blood loss or symptomatic anemia. Transfusion thresholds are generally lower now, often aiming for a hemoglobin around 7 GDL is acceptable in many stable patients.
Considerations.
Always weigh risks versus benefits. Risks include infection, reactions, storage issues. Conservative transfusion strategies often lead to better outcomes than liberal ones.
Platelets, when are they transfused?
For low counts, thrombocytopenia, or poor function, especially with active bleeding or before surgery, if counts are very low. Also used early in massive hemorrhage, but generally avoid in TTP or ITP where they might worsen things.
Fresh frozen plasma, FFP, replacing multiple factors.
Yep. Used for severe bleeding with likely multiple factor deficiencies, think liver disease, DIC. Also key in massive transfusion protocols to prevent dilution, and for rapid warfarin reversal, or specific factor gaps if concentrates aren't available.
Cryoprecipitate, more specific, right?
Yes, it's a concentrated source of fibrinogen, factor 8, VWF, and factor 13. Its main use today is treating low fibrinogen levels, hypofibrinodemia, seen in DIC, massive bleeding. Can sub for factor VI-VWF if needed, but concentrates are preferred.
Desmopressin, DDAVP, we mentioned it for VWD and uremia. How does it help bleeding there?
It triggers release of stored VWF from endothelial cells. This boosts platelet adhesion and transiently increases factor 8. So it helps in mild hemophilia A, some VWD types, and can improve platelet function in uremia, but doesn't generally help reduce bleeding in patients without these specific disorders.
Vitamin K and protamine-specific reversal agents.
Exactly. Vitamin K for warfarin reversal, slow, or liver dysfunction. Protamine sulfate specifically reverses unfractionated heparin.
Factor A, recombinant, when's that used?
Approved use is for hemophilia patients with inhibitors. Off-label use is grown in severe bleeding like trauma or cardiac surgery, but evidence for mortality benefit is limited, there's a thrombosis risk, and it's very expensive. Might have a role in resource-limited settings or severe platelet disorders like Klansman's.
And antifibrinolytics, aminocaproic acid, tranexamic acid, how do they stop bleeding?
They block plasminogen conversion to plasmin, so they stop clots being broken down prematurely, reduce blood loss and transfusion needs in surgery. Tranexamic acid especially showed mortality benefit in trauma if given early. CRACE H2 trial. Generally safe.
Let's focus on bleeding during surgery. Initial steps.
Immediate step is usually direct manual pressure. If it's arterial bleeding, you need proximal and distal control fast to allow repair. Maybe systemic heparin if you need to clamp a major artery, and there's no coagulopathy.
Venous bleeding can be trickier.
Often more diffuse, vessels are fragile. Pressure, packing, topical agents often work. Ligation is usually better tolerated than arteries because of collateral veins.
The chapter details mechanical tools. Electrosurgery is common.
Very. Uses high-frequency current for heat to cut or coagulate. Monopolar needs a grounding pad, good for broad coagulation. Bipolar confines current between tips, safer near delicate structures, works in wet fields. Ligature is a bipolar device that adds pressure for vessel sealing.
Argon beam coagulator. Sounds fancy.
It's monopolar electrosurgery using a stream of argon gas. The gas blows away blood, allowing diffuse coagulation of raw surfaces. Great for liver or spleen bleeding.
Radiofrequency devices.
Like TissueLink. Use radiofrequency energy with saline irrigation. Keeps tissue cooler than standard cautery. Seals vessels by shrinking collagen rather than burning. Good for bone or soft tissue. Risk of steam popping if subsurface heats too fast.
Then the topical agents, lots of options. Mechanical versus active agents, what's the difference?
Mechanical ones provide a scaffold or physical barrier. Gelatin sponges, oxidized cellulose, collagen, polysaccharide spheres. They help the body's own clotting process work better.
And active agents.
They contain stuff that directly participates in clotting. Thrombin is the prime example. It actively converts fibrinogen to fibrin.
Let's hit a few examples. Gelatin, gel foam, and oxidized cellulose. Surgicel.
Gel foam is a porous sponge, promotes platelet adhesion, can soak up thrombin, can swell, so careful in tight spaces. Surgicel handles well, apply dry. It's acidic, helps hemostasis, antimicrobial, but inactivates added thrombin. Use minimal amount, remove excess.
Collagen agents and polysaccharide spheres.
Microfibrillar collagen, APTT, and STAT, directly activates platelets on contact. Use dry instruments, avoid nerves, remove excess. Polysaccharide spheres, Arista, are like tiny sponges, absorb plasma, concentrate platelets factors, no prep needed, but can swell.
Active agents thrombin is key. Different types.
Yes. Used to be bovine, risk of antibodies. Now we have recombinant human recithrum or human plasma derived, much safer. Available as liquid, gel, or on patches like Tocacil, human thrombin fibrinogen on collagen.
What about sealants? Fibrin sealants, thrombin sealants.
Fibrin sealants to seal, Efacel, mix fibrinogen and thrombin at application to form a fibrin clot seal. Strength depends on fibrinogen concentration, speed on thrombin. Some contain iproteinin, antifibrinolytic.
Thrombin sealant.
Like FlowSeal, gelatin matrix plus thrombin, provides tamponade and active clotting. Often works better than just gel foam with thrombin. Dry fibrin sealant dressings exist too long shelf life, no mixing. Tissue glues, bioglue, use chemicals to cross-link tissue proteins.
Newer agents mention chitins, chitosins, mineral zeolites.
Yeah, newer mechanisms. Conjugations, MRDH,
Huh.
HEMCON, are derived from shellfish shells, interact with blood components to promote clotting rapidly. Mineral zeolites, quick clot, are super absorbent. Concentrate factors activate cascade. Early ones got hot, newer ones less so.
And topical antifibrinolytics, lysine analogs like tranexamic acid.
Yes, applying tranexamic or imidacloprolic acid directly to the surgical site can help stabilize clots, reduce bleeding, especially in ortho or cardiac surgery.
Okay, fast forward to after surgery. If a patient starts bleeding, how do you know if it's surgical or medical coagulopathy?
Critical distinction. First, support the patient, then assess. Is the bleeding coming from a specific spot, likely surgical, or is it more generalized oozing? Suggests medical. Post-op labs, PT, APTT, platelets, fibrinogen, FTPs, maybe TT, are crucial here to check for coagulopathy.
And management differs based on that.
Totally. If it's clearly surgical, often means going back to the OR for direct control sutures, cautery, topical agents. Arterial bleeding needs urgent repair.
And if it's medical?
Then it's about treating the underlying coagulopathy, factor replacement, reversing drugs, transfusing components, correcting hypothermia, acidosis. Dilution is also key. Going back to the OR without a surgical target usually doesn't help and can be harmful if it's a medical bleed.
This has been an incredibly thorough deep dive. Amazing how complex this system is. To wrap up, what are the absolute key takeaways for our listeners?
I think the main thing is that hemostasis is this incredibly intricate balance. Bleeding problems can stem from a huge range of inherited or acquired issues. Getting the diagnosis right using history, exam, targeted labs is absolutely essential.
Right.
And treatment has to be tailored to the cause. It might involve blood products, specific factors, reversal agents, antifibrinolytics, or those sophisticated local measures we talked about during surgery. It's not one size fits all.
Were there any surprising facts or details that stood out to you from this material?
Well, the widespread off-label use of factor A, despite limited mortality data and the high cost, is always interesting. And maybe the technical point about steam popping with radiofrequency devices, a reminder that even advanced tools have quirks.
And why should our listeners, whether they're healthcare pros or just curious, care about all this? What's the relevance?
Understanding hemostasis gives you a real insight into a fundamental bodily process. It explains so much about managing common issues, surgical care, trauma. It highlights the body's incredible complexity and the delicate balance needed for health. It's relevant to almost everyone at some point.
Finally, here's a thought provoker for you. With all the newer anticoagulants and hemostatic agents constantly being developed, how might future research change how we prevent and manage bleeding? And what ethical questions might pop up as we get even better at tweaking this vital system? Something to think about. Thanks for joining us for this deep dive.